Welcome, everybody, to another virtual event. This year has just been a great lineup of conversations. Hope you've been able to catch some of the previous conversations. If not, everything's up on our YouTube channel. Would encourage you to go there, subscribe, and catch some of the previous conversations we've had this year. Tonight, we're going to be jumping into a conversation on medical education and its place in the world of healthcare missions. And I just can't think of two better individuals to speak with on this topic. We've got Kier Thielander and Bruce Dahlman. And so, guys, just thank you for joining us and sharing your wealth of knowledge and wisdom and years of experience with us.
Glad to be here.
Yeah.
Thank you so much, Luke.
Yeah, so we'll start out. We'd love for you guys to just kind of give an overview of who you are, a little bit about your two different organizations, and Bruce, let's start off with you.
Yeah, thanks so much, Luke. I appreciate being able to share with your audience about how God is using medical education and the opportunities we have to work with people for lengths of time for both discipleship and good quality education. So I'll just start off talking about the Christian Academy of African Physicians, and I'll try to share my screen here. I'll start off talking about the Christian Academy of African Physicians, and our goal is to give you an overview of the work ministries that we do in many of the same hospitals and places across Africa.
That's great.
So just an introduction myself, I worked for 15 years with Africa Inland Mission at AIC Kajabi Hospital as medical director, and starting family medicine in the country of Kenya. And our organization's mission is to support programs to teach and mentor African physicians in the primary care areas so that they can empower the body of Christ to continue the teaching and healing ministry of our great physician, Jesus Christ. So it's an organization that supports people that are working with educational programming and coming alongside them with the vision to engage the healthcare system to provide compassionate care that exemplifies the healing power of Jesus. So first slide is always important. Healthcare workforce issues are huge. And as you can see from this very demonstrative graph, the ratio of physician availability to the population is just staggeringly small in Africa as compared to most of the other parts of the world. Wow. So there's those issues, of course, but there's also the issue of the ministry challenge, the unreached peoples across the whole earth. And we all probably are aware of the 1040 window, and you can see across Southeast Asia, India, into the Middle East, there's lots of groups, but then look at Africa, all across the Sahel, we call it, the lower part of underneath the Sahara Desert into the Western Africa and across East as well. Many people groups still without the knowledge of Jesus. So family medicine is a specialty that is often new in countries of Africa. However, the church has been an instrumental part of starting family medicine as one of the specialties that we work with. Nigeria started family medicine in the 1980s. There's still about a dozen church hospitals there. Uganda and South Africa began in the 80s and 90s. After a meeting in Kenya that I participated in 1995, DR Congo went back and started programs in their hospitals for the first time in that country. Kenya came along in 2005. Church hospitals were again the instrumentation of getting those programs started within the educational and accrediting agencies of the country. People involved in the Horn of Africa and in Ethiopia. Many of church and missionaries were involved in getting things involved in those countries. Malawi also has had a strong interest in family medicine through the university, and church hospitals participate also in Liberia. And this is only the ones that have started in the past. Internal medicine is also taken off. Cameroon started over 15 years ago and has been a strong program, was able to birth a sister program in Egypt this past year. And other larger specialty hospitals are probably coming along with both internal medicine And then hopefully into the future, we can complement that with the pediatrics, emergency medicine, and of course, one of the major areas that the whole continent needs is help in the mental health psychiatry area. We are very good at sending chaplains to the wards and making sure they're saved. But boy, there's a lot of mental health issues that are concomitant with their spiritual and physical needs. And that is only just beginning to be broached with a great program that's been starting at AIC Latane, and CAP hopes to multiply that into the other hospitals as well. So this is the map of where CAP is currently working in the green, where we hope to be coming in the next couple of years as we've made overtures and made connections to hospitals that are either ready to start or in the planning stages. And then some places where we've had inquiries, including, I didn't put Madagascar there as well. So there's a lot of places, and you'll see from the map that PAACS will present, we overlap significantly and hope to overlap completely into the future. So yes, we're a lot younger than CAP. We're only a few years in beginning our network, but these are the graduates from these programs thus far. And you can see it'll expand significantly. We're heading to Nigeria in another month or so and engaging the dozen programs there, and hope to see them come on board, and that'll increase our activity across the country. So you'll hear a lot of repetition. Our interest is not just excellent medical training, but of course, spiritual development and growth of the individual's ability to not only share their faith, but be able to lead others and teach others as they become the leaders of these programs into the future. So CAP is rolling out a spiritual development program. We call it the 4 Fs, emphasizing these different areas of spiritual development. And we hope that as we encourage and supply materials and training, that this will become an increasingly important part of how these church hospitals are preparing these young doctors. So our curriculum is, so the ways we help is through supplying assistance for curriculum. One distinction between PAACS and CAP is that we usually are working within national systems, because family medicine, especially as it starts, has to kind of prove itself. It's a new concept, new idea. It needs to work within the constraints of the accreditation process so that it's accepted as an equivalent specialty. It's kind of a burden we bear, but it's something we engage with actively. But it does mean that we don't have a one solitary curriculum, because each country looks for different formats. Then the more important parts that we can come alongside are health professions education, meaning faculty development, ways to help teachers be the best they can be. So trying to work away from the assumption that if you're a good doctor, you're also a good teacher. Well, maybe, but not always. And so we want to be sure that the resources are available for not just the named faculty, but as we know, you learn a lot from your peers. So we want the residents themselves to be versed in how to help educate both amongst their fellow residents, but also for the others that are in their team, the interns and some of the other cadres that are on the rounding team with them. And then we're encouraging that so that everyone is understood to be a lifelong learner and teacher, and maintain the humility as a learner for the rest of their lives, and not when they're done with their program say, well, I've arrived and therefore I don't need to listen to anybody. So those attitudes are probably more important than anything going into the future as a excellent clinician.
Yeah.
So if you want more information, the slide is there, and I'm sure Luke will have these posted on the website so that you can get back to us to talk more. Obviously very interested in talking to anybody that's interested in becoming a faculty member, either short or long term. Their needs across the world, and essentially the major constraint is people who are willing to serve. The money can find that usually somehow, somewhere. People, we're always open for the phone call or the email or the WhatsApp call. And what's wonderful too, I think Kier will also mention, is that God is preparing these graduates from our programs to become the really excellent faculty, both in the quality of their medical care and the fact that they can disciple in ways that perhaps cross-cultural missionaries wouldn't have as deep a knowledge of. So we're really excited about the way our graduates are taking their places as leaders and shakers as well, giving us new ideas and expanding our vision for how God wants to see the nations come to his throne. So give it over to you, Kier.
Yeah, thanks, Bruce. Real quick, just before we hand it off to you, Kier, Bruce, appreciate the comprehensive overview there. Just awesome to see some of the stats there, where the needs are and how you guys are specifically addressing those. And so, just thanks for giving us that overview. And definitely, we'll get this information to you guys. Just keep an eye on your notification. We'll get those links out to you guys so you can follow up more and reach out if this is something of interest to you. So. Kier, let's hear a little bit more about you and your organization.
Yeah, definitely happy to share. Bruce, that was great. Always impressed with what God is doing through CAP. Happy to share a bit about PAACS, but a bit about myself first. So I'm Kier Thielander, currently Executive Vice President with PAACS. Bit of my background, I'm a general surgeon, trained in the U.S., and then spent 10 years in Bangalo Hospital in Gabon. During that time was doing training and discipleship. Then in 2016, took this position as the now Executive Vice President with PAACS, where I oversee what we do on the continent of Africa, which I'll be telling you about here in just a minute. So PAACS is the Pan-African Academy of Christian Surgeons. We have our tagline of training with excellence and discipling in Christ. It really encompasses the two main emphases of what we do as an organization. If I can get this to move. So give a little bit of context, as Bruce did as well. The surgical need in sub-Saharan Africa is immense. As you can see in this from the Lancet Commission 2015, put this together, recognizing that sub-Saharan Africa, the darker color means a greater need, as one might assume. And so sub-Saharan Africa, the medical need is just enormous. Back in 2008, a well-known physician, very globally interested, global-minded healthcare person, Paul Farmer, who has subsequently passed away, said this: surgery is the neglected stepchild of global public health. Again, back in 2008, that was the perspective. We're going to hear a bit of an update on that here in a second. So in that context is when PAACS was founded in the mid-1990s to 1996. You can see one of the earlier photos from about 2000 of some of those who were involved, and a few of our residents there in the front row. Our vision has evolved over time, but most recent vision is that PAACS envisions a growing number of African surgeons and related specialists living out the gospel and ministering to the sick. You may sense some similarities between what PAACS is interested in doing and what CAP is also interested in doing. Our mission is to glorify God first and foremost, and we could just stop there. And we could stop there because as we live out who we are, if you're a surgeon, if you're a trainer, if you're a discipler, then the rest of it is just natural, and that's what it is to glorify God. But we do expand on that by saying, by training and discipling African surgeons and related specialists to become Christ-like leaders and servants, providing excellent and compassionate care to those most in need. That's PAACS. Another way you could say that in kind of a scriptural background for what we do, these things you've heard me say in the presence of many witnesses, entrust to reliable people who will also be qualified to teach others. That's Paul communicating to Timothy what he ought to be doing, and that is what we take for PAACS today and what we ought to be doing, and would argue that really all of us ought to be doing that whatever our sphere of influence is. The context today is global health and medical mission training, medical training in the context of missions. You've heard from CAP, and now we're talking a bit about PAACS. To give an update from Paul Farmer's comment in 2008, when he was inaugurating the Center for Equity in Global Surgery at the University of Global Health Equity in Rwanda, his comment was, surgery is no longer the neglected stepchild of global public health. This is 2022. He passed away just a few weeks after that. And I think we walk in that, we embrace that aspect and hope that the global health community is now engaging in embracing surgery as an important part of global health, not just something that some people need. but a significant and integral part of global health. How does that look within PAACS? As Bruce alluded to, and as I will explain here, our surgical training, which also includes, we have anesthesiology training in obstetrics and gynecology, varying terms of the programs, but the general surgery program being the foundation is a 5-year program. You can see the number of different aspects of that training. It would look much like a training program in the U.S., which is where I'm located today, giving this talk. Is in the U.S. with one exception. You see Bible study. I don't know many programs here in the U.S. that do anything with Bible study in a formal way, but that is an integral and non-negotiable part of what we do within PAACS. We do implement this at rural-based Christian hospitals, which I'll demonstrate a little bit later. So our program and our spiritual training is a discipleship-focused 5-year curriculum with pastoral and theological education. That is something that, as I share about our strategic plan, we are leaning into more heavily in these last couple of years and plan to do that into the future to bring our spiritual training up on par in the same recognition kind of way that our surgical and obstetrics and gynecologic and anesthesiology training are already viewed. One way we do that is you can see we have different books. This blue book, they're colored, so we have a blue book, and there's an aspect on a book of the Bible, so the Gospel of John, something about character, something about God, something in this case about leadership or how do you behave as a graduated surgeon or anesthesiologist, and then something about ministry. So there's that general setup of each of our spiritual curricula. We have 5 different books that are included in that. Our current programs, we've grown. Now we're at 26 different programs, 15 general surgery. As I mentioned, that's the foundation of who we are and what we do. Those 15 general surgery programs are at 15 different sites. And then we have each of anesthesiology, cardiothoracic surgery, head and neck, neurosurgery, OBGYN, pediatric surgery, 3 orthopedic surgery programs, plastic surgery, and most recently, pediatric orthopedic surgery fellowship. So the family of PAACS training options continues to grow. Most recently, we've added the country of Angola as a training site that we have at a place called CEML. It's in Portuguese. I don't speak Portuguese, so I'll just say CEML. We're excited to partner there in a place where there's less than 100 surgeons for over 30 million people. They need surgeons to be trained. In the setting and context of the first map that I showed, obviously Angola would have huge needs. And then we just started the pediatric orthopedic fellowship. As of today, we have 172 trainees in all of those different disciplines, 156 graduates in our 26 programs. And I want to highlight on this slide, and you can see the growth of those different aspects of programs and residents and graduates, but I want to highlight the down in the left corner of 43 of our PAACS graduates. So that turns out to be about 1/4 of our graduates stay within our training programs as educators for the future to maintain and sustain those programs. We may get into that a little bit later, maybe in some of the questions about faculty makeup and some views on that. So happy to share a bit more later. Yeah. Continue on with PAACS. Here's where our current training programs are in the list of the hospitals. It's a bit of a busy slide, but you can see the highlighted countries are where we have training programs. It's currently 12 countries with those 15 different programs. Our graduates are working in 23 different countries. You can see that list here. We don't quite cover the whole map of Africa. Maybe someday the Lord will provide that we can, where we have graduates in each of the countries of Africa, but that's not the case today, although we aspire to that and we trust that the Lord will open those doors in the coming years. Some things about our current strategic initiatives. As I mentioned, our strengthening of our spiritual development programs. We've leaned heavily into that. Part of that includes training the disciplers. So that's discipling the disciplers. I think Bruce also mentioned that about CAP, that we really want to invest in our graduates to become those future disciplers, as well as we recognize that just because you're a surgeon doesn't mean you know how to do it, and a Christian surgeon doesn't mean you need to know how to do anything about discipleship. And so this is part of that program, as we're investing in those leaders. Developing opportunities for our residents to become faculty. Obviously, there's a pathway for that. We have 43 who have done that. 43 of our graduates. Faculty training program, which is extremely important. As I mentioned, just because you are a Christian surgeon doesn't mean you know how to disciple. It also doesn't mean you know how to teach. And so we do training programs on how to be a better educator. And then goal number 4, we've blown that a bit out of the water, I should say God has, as we've opened quite a few new programs since 2021 when this strategic initiatives were embraced by the board. Just going to flash up a slide here with a number of our different partners. You can see CAP there, CMDA. You can see quite a few others that maybe some of you who are listening in and watching this may recognize some of these partners. Collaboration is really the name of the game today. It shouldn't be a surprise to us. That is what being the body of Christ is. When you live in community, it's about working together in collaboration. And so we seek to do that in the way that we work with the mission hospitals as the training sites. We don't run hospitals, we just do the training part. Collaboration can be messy, but it also can be an amazing reflection of Jesus. I'm just going to put a little shameless plug in for those who might be interested in being a part of PAACS. This is our development program. It's relatively new, started in 2023. So we've just been doing this less than a year. And we have a number of times for students or people in a gap year, med students or residents to connect. It turns out there's not a lot of people at any given site that are interested in being involved in medical missions. And so to try to connect people across different areas, much like this webinar that we're doing here today, trying to connect people so that they can get engaged. I don't have a slide with my information, but PAACS.net definitely has all of my information. And there's the very surgical update and information about PAACS and who we are, and a little bit about myself as well.
Yeah, well, thank you so much, Kier. Yeah, so good to hear about what you guys are doing. Love the emphasis on leveraging your expertise and your sphere of influence for the glory of God, and then turning around and training others to do the same. Super cool to see how you guys are doing that, and even seeing so many of your graduates come back and begin training as well. Very cool to hear. So real quick, as we kind of move in kind of the next half of this conversation, we'd love to hear, give us a little bit of the history, the backdrop of healthcare education by the church and mission hospitals. We'd love to get some context there.
Well, the church has been involved for a long time, and we're standing on the shoulders of some incredible giants. The Presbyterian mission in South Korea in the 1880s started a medical school, Yonsei, and has been producing physicians in that hospital for 150 years. And following on also in India, places like Ludhiana, and a well-known hospital today, Vellore Christian University, as one of the leading hospitals in all of India, was started by Ira Scudder and has gone on to become a huge promoter of not just excellent medical care in their community, but spawned programs for medical mission as well. So these backdrops are where we're fitting into as both CAP and PAACS. In Africa, I'm thinking of Kilimanjaro Christian Medical Center in Tanzania. Been there since the 60s with the Lutheran investiture in the north part of Tanzania. So there's a lot of excellent examples. The issue really is if it's hospital specific, it doesn't have a chance to grow. So these organizations that have come up now, PAACS and CAP, are there to assist any hospital across the spectrum. And in Africa, I mean, the initial allopathic medicine of Africa, of course, is the mission medicine. It starts with the missionary having a little kit in their kitchen and handing out medications out the back door, and grows to a little dispensary, and then grows to caring for the missionaries. And then you look around and you say, oh, the needs are great in our area. We need to help the local population, and hospitals grow. And now many of them are incredible teaching centers. And an example that PAACS would give is a thoracic surgery training program in one of the church hospitals, Tenwick Hospital in Kenya. I mean, that's an incredible expansion of how God has enabled the churches to grow. So the history is rich, and we grow on the foundations that have been laid, and the hope is that we can expand this now. And I mean, if the Lord would will, every church hospital would be a teaching hospital, because the needs are that great. And as we know, teaching always inspires a lot more accountability and makes sure the quality increases as well. So it's an important part of where we're headed.
Yeah, Very cool. Yeah. So, someone who's not an expert in this domain, the assumption would be, what's the government's role in, providing this type of education, meeting some of these needs? I would think it'd be fairly high. So talk to us a little bit about why Christian hospitals specifically need to get involved in education at the medical school and residency levels. Kier, would love to hear from you on that for starters.
Yeah, sure. Yeah, thanks, Luke. I think it's, there's some interesting backgrounds that we can think about the provision of healthcare and the view on provision of healthcare and training. And you look at an area like sub-Saharan Africa, or the majority of the continent, actually, overwhelming majority. And it takes a critical mass of people to be able to do training. You can't provide care at the same time as training. Training takes time. It isn't something that you just add on. You have to dedicate time. And so in a governmental setting, the ability to be able to train for the future, the throughput is just not there. If you think most of the countries in the context where we work, independence was in the 1960s. And since that time, they've had maybe their own training programs, but I'll take Madagascar as an example, with over 20 million people, and they were training 2 surgeons per year. You don't catch up with the needs if that's all you're able to do. And so some of it's a view on training, some of it is an allocation of resources, and some of it, to be completely frank, is brain drain. And so if people keep going away to be trained and they don't come back, they need to have their own local training programs. The other thing I'll partner with this aspect of government is there are many countries in Africa that a significant percentage of healthcare is delivered by mission hospitals. And when that's the substrate of being able to train, is you actually have to do the healthcare, then you need to be able to embrace the people that you're training to engage them into that location. If your throughput in a government institution is not very high, or the resources aren't there, it's hard to do training. There's also a slightly different philosophy. In the US, our medical school training leads to a residency. Residency is compensated, and you're working, but you're providing care. And a lot of the government systems in Africa and the educational systems, it's what's called a master's in medicine, where the emphasis is still on paying tuition, which not everyone can afford, as well as on classroom learning, as opposed to clinical learning. And so the systems that both CAP and PAACS would advocate for would be more reflective, or more reflecting of what happens in the US, where it's on-the-job training, we could say. It's not apprenticeship, they're programmatic, but it's on the job. And that's in a contrast to the context that we work within. And so our program specifically, I can't speak to CAP. We have 40 spots. We'll have over 350 applicants for our 40 spots this coming year. Because it's a coveted program where people know they're not just going to learn book work, they're actually going to learn how to be surgeons by the time they graduate.
Yeah. I'll add on a couple of additional points here. One is just the issue of, I'm going to call it poverty. It could be said other ways, but medical education is an apprenticeship. As Kier is saying, along with the important academic learning, but that means you have to have people to do the actual mentorship. So in PAACS, Kier would talk about the close mentorship that a teacher has with the student at the table for extended periods of time, refining and making sure that the fine points of the craft are learned. Same thing in medicine. If you don't have a faculty person at the bedside when a patient presents with their collection of symptoms, and it's a mystery as to where this is going to go, if there isn't somebody to help the learner guide their thinking and their critical thinking aspects of what is the possibilities here, and what should I be thinking about? What's the differential diagnosis? If the person isn't really have a person to turn to right then and there to ask those questions, then the learning opportunity is lost. Mm-hmm. So what often happens in a government setting, because of the stretch thin of all the academics in these centers, is that the person knows the most, the professor, or even the higher ranking residents in the program, they're slam busy, and they don't have time to work with the juniors. So they're just on their own so much of the time. Not that they want to be, not that the faculty wants to be scarce, but there just isn't the volume of faculty available to give that closer training. Both PAACS and CAP, that's one of the most stringent things we have in our programs, is to make sure that enough faculty are there so that the learners have that ability. The other major area that I would point out is geography. All of the government programs start out with their teaching assuming to be only in the 1,500, 2,000 bed national referral hospital. The academic setting is the quotes only place where learning can occur, is where it comes from. Thankfully, all these government programs are actually moving towards a more diversified model. But by the fact and geography of where church hospitals are placed, 90% of them are in rural areas where the needs are. And the disparities of distribution of doctors across these countries in Africa is huge. 80% of the physicians in Africa are working in those city areas where only 20% of the people live. Africa is still a very rural area. So 80% of the people in these rural areas being served by 10 to 20% of the doctors in total. And those doctors that are serving are usually the newest products. They come out of internship, 1 year of training, thrown into a small district hospital or even in the church hospitals, and expected then to do the C-section first day when they've never even done one sometimes. And those disparities not only make it difficult for quality patient care, but as I say, there's no better vaccine against going into rural primary care than thrusting somebody into a setting unprepared. They come out of that emotionally scarred, and today we have terms for it. We call it moral injury. We call it PTSD. And those physicians go back to the city saying, give me a super specialty where I only know half a little bit and where I can have lots of people around me. And that becomes then the ongoing disparity of these needs. So the church hospitals, PAACS, Kier, you can speak for PAACS, but for the family medicine programs that are in these rural places, the doctors are staying there. It's making a difference in terms of long-term investment in hospitals where there's continuity of leadership from the medical side as well as an administrative side. That alone makes a difference, not just that the quality of care that they're providing is better.
Yeah, absolutely.
Yeah, so good. So it sounds like you're addressing several things here. You know, we look at like the numbers gap between medical school graduates and residency places available. And there's this quality gap, like between quality and quantity of resident supervision, and then this placement gap. Residents tend to stay and serve in the region type of facility in which they train. So the church's involvement is kind of filling those gaps. Is that what I'm hearing?
Yes, by design and then by default, by the fact that these hospitals were all established in these more needy areas.
Yeah, it's interesting to hear you talk about that. You know, the places where the care is needed, you know, all the doctors are going to like the city areas. It's, you know, we see something somewhat similar in the United States from what I've heard, where you'll have, like patients competing for doctors and doctors competing for patients. And so it's, interesting to see how the church can step into that and really provide the care where it's needed. That's really, really important. Maybe talk just a little bit about kind of the unique opportunity of this holistic approach to integrating, you know, like I'm in the mental health field, so we would talk about it like a biopsychosocial spiritual care. So like this holistic care of a person. How does that play out in the work that you guys are doing?
I'll take it first, and then Bruce can certainly clarify or add, because the family medicine approach and holistic would be more, in some ways, more applicable. But we recognize on the surgical side that, and I'll add to that, not just the holistic care of the patient, but the holistic training, right? So we're talking about training programs, medical education. And we want to talk about holistic care, but we also should talk about that we're doing holistic training. So we're training in discipling, in mentoring, in spiritual training, as well as psychological care for your patients, and in understanding that they don't just come with appendicitis, they come with a background. They come from a village that has certain ways of thinking. They come from a family that may or may not have resources. In most cases for us, they don't have resources. And so this holistic aspect includes, how do we address some of the financial burdens? What does that look like? As some people are fond of saying, and I'm one of them, although I don't like it to be true, the worst business investment is a mission hospital. Mm-hmm. It's never going to make money because they all got put in places where nobody had anything. That's why they were there, right?
Right.
So to think that a mission hospital can be self-sustaining on its own income is crazy, because the patients they're caring for need financial assistance. So how does that look? The other aspect is their spiritual care and spiritual needs. Not only do they come to a hospital with spiritual needs, even if they accept Jesus, how do we get them plugged back in to their community? And so there's an aspect for our program that we engage the chaplains to make sure that that aspect is understood. They know all the villages and the other pastors much better than we do as surgeons, and yet we can still share the gospel. I don't know all the villages in a certain site, but they would. And so they can connect someone back to the pastor in that village so that they have a place in a community to reconnect in, not just their village, but in the church community of their village. And so the whole holistic aspect includes those things that we don't think about the finances as much in the US. We certainly don't think about the spiritual care here, to our own detriment as a culture. But we have that opportunity to do that, because when people come to a mission hospital, they know it's a mission hospital. They know they're going to hear about Jesus. They expect to hear about spiritual things. And if we don't provide that to them, then they wonder why we don't love them or care for them, because we're a mission hospital after all. They should hear about spiritual things. So we can take advantage of some of those expectations to provide that holistic aspect, not just take out their appendix, but talk to them about their community, talk to them about Jesus, and talk to them about their financial burdens.
Yeah, that's so good. You mentioned a little bit there about kind of funding for these hospitals. Let's move into that just a little bit more. So talk to us a little bit about how.
Just to add, I have to add on to that.
Please do.
Bit.
Please do. Yeah.
Spiritual care. What's in the differential diagnosis when somebody comes in with what we would call a psychiatric illness? Okay, so DSM-5 has a very exhaustive list of psychosocial diagnoses, and if we put our Christian overlay in terms of knowing about spiritual powers on top of that overlay, there are places where people are actually coming to us with the need for a diagnosis that's in the spiritual realm, not just in the medical or mental health realm. People are affected by spiritual powers. Now, it flips the other way too, because in many cultures, because they're aware of the spiritual nature of the universe way more than our Western culture is. That's how they understand things from the beginning. So when Kier says we need to be involved in that because that's what they expect, yes, they have to be, because Christ's name has power over the spiritual forces of this universe that sometimes need to be engaged and be driven out. All right. Kier probably has had those experiences. I have, and we see them, every day. And I always say that I would understand the mission of CAP to be finished when every resident entertains within a differential diagnosis, when appropriate, these spiritual diagnoses of when a person needs to be confronted. The spiritual powers that might be a part of this complex need to be confronted and dealt with, just like we would do with surgery. The appendix has to come out. So does the spiritual oppression that might be in this person. And that is an important piece that you're never going to get in an education across, our secular world, right? But yet, when I go to Kajabi Hospital and go onto the ward for the first time as a young doctor in 1992, the nurses are teaching me that, okay? And I had to learn what it means to work in the spiritual nature of our work. And of course, that's what we intend and expect to be a part of the training, and that is in the programs that we're setting up, because that is a part of our work as healers.
Yeah, I mean, in talking about such a sweet spot for the church to engage in this in a way that other programs can't. So as students come to you guys to learn, this is like maybe one specific thing that sets it apart from other training opportunities, is that holistic care and thinking about kind of that spiritual engagement and how do we work with patients on that level holistically. Super important.
Yeah. Thanks for letting me add that on.
Yeah, no, glad you did. Thanks, Bruce.
Yeah.
So let's talk a little bit about funding. I think it's interesting to hear about how are these programs funded. I mean, that's such an interesting conversation when we're talking about serving people that can't pay for the care they need. walk us through that. How does funding work? How is it different from government hospitals?
I'll take
Go
a
ahead,
lead.
Bruce.
Yeah. So it's of course quite varied. Most of the countries of Africa, in their plans for delivering healthcare to their population, intend to, or hope to, or in many cases have begun some kind of a national health program where everybody can, if they're paying in a small amount every month, they're in a plan that insures them so that if they go to a hospital, they can be covered. Now, there are inequities between how governments will pay a church hospital versus a government hospital. All hospitals often get paid late and way after the fact. And so the care is delivered, the salaries are paid, but the money for that care isn't on the table. And it makes a very significant stress on all the system. In Kenya, as the example, the government pays the salaries of their workers in hospitals. That's 50% of the cost of what goes into care in a hospital. That's all paid through the treasury, through the counties. So it doesn't even have to be collected from the insurance plans that are put in place, whether it's government or private. And yet the church hospitals, they're private. They're on their own. Most of the time they get their government funds, when they apply, but there's no 50% check coming from the government for the salaries. Okay. So that they're inherently inequitable payment schemes, and yet the church hospitals survive. And the question really is, how in the world has God allowed them to survive this long with that great a disparity? And the answer is because people know what care and compassion is when they go to these hospitals. And they'll bypass one or two others before they'll come to the church hospital. And you ask them why, and the surveys have been done. It's because I know they'll care for me, or I know that they'll do what needs to be done and they won't be languishing for days without getting the needed care. So that's part of the funding piece. Education funding is a whole nother aspect here. And in the U.S. system, people don't realize it, but it's the Medicare taxes you pay that come back to pay for the residents that are being trained in any hospital. So a hospital in this or university in this system gets paid a chunk of money, for every resident that's in their program, and that's how they're sustained. That's how the salaries are paid. So when a hospital, a church hospital, wants to send their aspiring medical officer to a government program, okay, the government will take their residents that are selected, and the salary they're already paying them in a hospital follows them into the training program because it's all from the government treasury. Yet a church hospital physician who wants to be sent to that has no government salary. So the church hospital is paying a salary for them to go to the government program, and then has to pay for the person to come and backfill the position that they just opened up by sending somebody away. So they're having to double pay. Another hit on how the church hospitals are trying to do that. So one of the reasons that PAACS and CAP need to exist to get these training programs going is so that the training is happening in the hospitals where these residents are coming from, so that they're not having to double pay. All right. And why we want to try to expand as broadly as we can for that reason alone. So church hospitals, they're operating on a shoestring already, as we already talked, which means that they don't have money to pay for the extra person. And it is an extra person you're paying for when they're training at a hospital. They have to have food on the table as well. And so there has to be some backdrop for the training for the salaries of those residents. And Kier, maybe you want to talk a bit about how PAACS does it, and I'll add just a bit on how CAP does that.
Yeah, just to tag on to what Bruce said, you take a hospital in one of the poorest areas of the country, because that's where mission hospitals almost all are, and then expect them to be able to fund something like education. It's just not going to happen. They don't have the money for that. They barely have the money to pay their staff, as Bruce alluded to, and sometimes that payment is even delayed. Salaries are delayed, and of course, as we all know, in every setting in the world, if you're the student, you're the weakest member, and you can be guaranteed if you were supposed to get something, you will get it last. The administrators will get their salaries before you will get yours in most cases. That's not always true, but in a lot of cases. So for PAACS, we collaborate with our institutions and provide a significant portion of the cost of training a resident. So our role is the educational aspects. So that's a stipend for the resident, that's costs of rotations, that's registration with colleges of surgery that they will need to ultimately be certified by. COSEXA is one of those. There's some others. We'll get into all of that. And then we also provide other educational needs, things like projectors and whatever else that is needed that the hospital otherwise would say, we wouldn't do this if we were not a training site. And so PAACS really brings in those kinds of resources in a similar way to, like Bruce was saying, where Medicare funds that here in the US, hospitals here that in one of the wealthiest countries in the world, we can't pay for it as a hospital. So to think that the hospitals in local settings in the poorest areas of the world can pay for it is not right thinking. That's just not, there's no logic to that. That's wishful, it's hopeful, it's magical thinking, but it isn't going to work. And so PAACS fills in that gap. The hospitals provide the things that they can reasonably do, like housing and some other things that are expected of them anyway. But from a financial day-to-day, month-to-month, year-to-year situation, PAACS provides the majority of that. Our funding comes from generous and unbelievable donors. For the most part, we do have some grants that we've solicited and received. And we have some churches that are partners with us, but primarily it's individual donors that see the impact of our training programs as well and in those local hospitals, but also the impact of our graduates. And that's what says, oh, I'll give to that because I can see what's happening. It's a proven track record. And so that's our model. And the funding of it, as Bruce said, I won't get into that too much other than to reiterate the point that to think that mission hospitals can do this on their own with the amount that they receive from charging for care is magical thinking. It is not feasible. It doesn't make sense. So I'll just reiterate that point. Some may say that's my personal view. I would argue, show me where it's not true. Yeah.
Well, I guess the way to say it is that there is no sustainable hospital in the world. Okay.
Yes.
All healthcare at the institutional level requires a means by which the bill is going to be paid by a shared model, i.e., insurance. All right. And when there is no insurance, then where does that sharing come from? Well, in Kenya, there was the Harambee system. You go back to your village and you ask the chief if you can hold a Harambee to gather funds at the village level to bring back to the hospital to pay your bill. And quite frankly, there's in some ways the church hospitals, are almost the most sustainable in the aspect of the fact that patients are paying for their care directly, okay, without any government or insurance funding coming in. It's kind of almost the most sustainable, if you will, in that sense. The problem is, of course, that the resources the people have to pay, as Kier is saying, are way less, and yet the integrity of the people to actually pay the bill when they have so little is quite incredible. Absolutely. Now, it's important, I think, and Kier would be first to jump with me on this. We have incredible partners. So partners of individual donors.
Yes.
But let's do a couple call outs for CAP. It's MedSend. So most of our programs are tapped into a group called MedSend, which is an organization that raises funds to help both expatriate missionaries with their debt, so they don't have debt holding over them to be able to leave to come to Africa and other countries of the world. And that's been a great program for over 30 years. In the last 10 years, they've initiated the National Scholars Program. So assisting the church hospitals by supplying the funding for the small stipend. It's a modest stipend. It's less than what the government pays for their dot. So it's not like they're being overly generous. It's being basic meat on the table, kind of stipends. MedSend's been doing that faithfully now for a number of years and following where CAP has been growing into. And the other major assistance to our programs across the board is Africa Mission Healthcare, which has been a very generous funder and taking on education at this level as one of their main ministries and giving, helping with funding for additional housing that's needed at every one of these places. When you add staff, There has to be a house. There has to be a place from the state. It's rarely available in these rural areas of any standard that would be acceptable to anybody for them to do. They can't just go down the street and rent. So it means building a quality home that they can be safe and home and cared for. So these two, and there are many others as well. I call them out because they're the ones that come to mind that are really come behind us and really are excited about the work that God is doing through CAP and PAACS.
Yeah. I think if I could give a little bit of a summary here of that funding or finance aspect, but also it runs to everything, and that is the community aspect that happens to need to look like the body of Christ. There's no individual aspect. As we seek the idea of diversity in the U.S., we ought to be seeking diversity where we also minister. And the idea of sustainability or nationalization, which says it's all you who all look the same, but not us who look different, whoever the us and you is. I'm not a believer in that. I think I think Scripture teaches us the body of Christ is diverse, and we should bring the kingdom on earth. And to do that, we need to look like the kingdom. And to look like the kingdom, diversity is required. So the idea of the ongoing engagement, whether that's financial or that's participatory, whether that's human resources, whatever it is, that's what changes people, and that's what sends a message in Africa and everywhere around the world. I don't understand how these people do what they do, and we can say, yeah, we know how we do it. It's Jesus, because we actually aren't doing it. It's Jesus.
Yeah, beautiful summary there, Kier. Yeah, absolutely. And you're starting to touch on, I think, where we want to go next in the conversation as we kind of wrap up here, the idea of need, right? We're talking to everybody tuning in here. Has a skill set to serve, has a desire to serve, and we're looking for ways to engage, right? And so this is one outlet, everything that we're talking about here. So talk to us a bit about the need, like why are long-term missionaries needed? What opportunities are there for short-term doctors to come and teach, right? I'm kind of throwing a few questions out there that I want to kind of sum up here. And how can the audience here learn about these needs and ways to engage?
Well, first of all, Luke, you got to remember the Great Commission that we all turn to in Matthew 28. It's a command. It says to go, and that go is, in a collective. The church needs to go, but the church can't go unless an individual goes. So we have to appropriate Christ's command to go as something that we have to consider for ourselves. Many people look at that, well, I need to have the lightning bolt call to make this decision to go. I'm not sure that's how it works. The command is to go. And if anything, I would say to you, the call needs to be whether you're staying or not, okay? It has to be a called out from the command to go to stay. That flips it on its head quite egregiously. Right. If you are reading and understanding, Christ's commission, he had 12 disciples. He commissioned them to go. He had 72 come to him. He commissioned them to go. And Matthew and John and Acts all talk about our need to look to our brothers and sisters across the globe as one of God's children. We need to go. So how do we do it? Well, we're here as CAP and PAACS to facilitate from the very first steps. If you're a medical student, even a college student, and thinking about, is God preparing me for this? We want to connect to you. We want to find out who you are. We want to help encourage you. We want to connect you to a mentor or a coach in your area. We want to give you the tools and opportunities and point you to the educational preparation things that you can do to prepare both spiritually and academically for a rigorous life. There is no two ways to say it. It's a stressful career working cross-culturally to teach in an area where you're just as you're in your training, you're learning yourself. How can I be a teacher? Well, what God is preparing in your heart in terms of a heart of compassion, taking a patient-centered approach, you're always there for the patient. Those qualities that are bred into you as in the educational systems of the U.S. and then as a part of who you are as a follower of Jesus, those are the things that have to be caught by the people that you're talking with. There's so much words can happen. What you leave by being there in the middle of the night when the patient needs you is everything to the teaching of the next generation of learners, whoever you are, whether you're here or there. That compassion is what we need. And so even if you think of, well, I only know how to do a certain limited set of things, or can I really take on this whole breadth of skills that might be needed? Well, the most important part in the teaching is that heart and that being there, and that I'm there to help you learn. I'm there to help make this patient have the best outcome. That becomes the most important part of what it means to come. So I can dispense pretty quickly, and Kier can too, with all the excuses that might be there, for why you can't go. Okay, and I'll just be upfront and say, for those that are younger and contemplating service, the number one reason that people don't follow through with their plans to go, and many people throw the card on the table at GMHC, and some of the major reasons why they don't go, the partner that they're choosing to spend life with. All right, if that person isn't equally excited and compassionate and called to follow that command, you won't go. All right, it's just as simple as that. And there are many other roadblocks, of course, to serving, but the goal, the beauty of the age today is that you can hop on a plane for very little money in relative terms to the past, where you spent months on a boat to get somewhere, to experience what it is, and to understand in context what is going on, and to just look. I think the first trip of anybody to go should be just to observe, just come alongside somebody. Don't plan on changing the world. It's going to run on without your two-bit performance the first time out. Just soak in what God's doing, and I think from that you catch the vision for how you might be able to plug in and make a difference, either short or long term.
Yeah,
definitely. If I could just add on to that, I would say it this way: when people ask me what does Africa need, my answer is usually you. And it's not money, it's not all that other stuff. And what I mean by that is, just as much as Africa might need you, you need Africa. And it's a mutually learning endeavor. This isn't, I'm coming from the West, I know everything. This isn't a one-man show, one-woman show. I'm going to show up and change the world. This is going collaboratively. This is going recognizing what you have to offer, not denying that you don't have anything to offer, and I'm just going to do whatever anybody wants, but also recognizing you're receiving. And so in that process of going, you receive a lot, acknowledging that you've received. And then I would add, having mentors, local mentors, international mentors, people who will keep you accountable to what commitments you've made, that you did throw that card on the stage. How's that going? How's that process working? And I'll add, Bruce, yes, it's true. Your spouse that you pick can be a problem in terms of going. It can also be the grandparents. They don't want to lose those grandkids. And so they can come up with all kinds of reasons why you shouldn't go. It's dangerous. There's snakes. There's malaria. The list is extensive. And then we can also put a list of things that are dangerous in the US, but we won't go into all of that. So the challenge to go is there. The call to go is there. And really, you're the one, whoever you are, you're the one that's needed. You have something to offer, and withholding that is not appropriate. You need to bring it to the table and provide it for others, and just as much as you acknowledge that you're going to be receiving as much as you're giving.
And bringing that with the humility that keeps you from the savior complex, okay?
Yeah.
And there's justifiable, pushback from the world to the way we have done things in the past. Yeah. And the attribution is that we're trying to save the world. Well, kinda, we know who the savior of the world is, okay? And it can only be known if there's somebody there to tell and to show by the love and compassion in a holistic way.
Yeah, so good. Yeah, we talked last month quite a bit about humility, but here on the flip side is you do have something to offer. And so leveraging that and bringing that to the table, I think you've been very clearly called out here what's expected. And So yeah, thank you guys for sharing that. Really quickly, just to kind of wrap things up here, I want to talk about preparing. Okay, so we've got people across the board here. Maybe people who have done a lot of mission work in the past, kind of refining skills. People who are on the verge of like really being ready to go in terms of their education, and then we have some younger people here in the crowd who maybe are in their undergraduate degree. And so, if you could talk just a bit about what ways can people in college be preparing for this type of ministry? You know, do they need to consider seminary training, Bible training? What would you tell people who are really in that training phase to be equipped for this type of serving?
Again, the first thing is you'll never be ready. So don't wait till you feel like you're ready, because you'll never feel ready. It's God who's going to do the work, not you. But practically, the things that you can do, you should do. And those things are like attending a Global Missions Health Conference or some similar conference, keeping yourself engaged with international activities so that you start to reflect who you're around. And if you choose to be around people who are focused on the next house and a bigger car and a bigger salary, then you're eventually going to default to that. If you choose to be around people on mission like you want to be, then you surround yourself with people on mission. You will also remain on mission. Have some international contacts. There's plenty of people that are in our spheres here in the United States that are international. They didn't grow up in whatever town you're in. Seek them out and learn about their culture. That is the biggest hindrance to people's effectiveness on this journey of medical missions, is the lack of understanding the cultural context that they're working in. And so learn about cultures now. Start to challenge some of your beliefs and the way that you view the world by interacting with somebody from somewhere else that maybe lives here, but is still very culturally where they came from. Those would be my strong encouragements right now, that things you can do no matter where you are, you can do both of those things.
Yeah, it's good. Yeah, there's always something you can be doing.
That. The most important part of service is to be humble, to learn. And the ability to learn from somebody that's different from yourself in whatever means or way is an important attitude that Christ asks us to be. And that is going to be in almost every community in the U.S. these days. All right. We are a very diverse culture, and there's lots of opportunities, but we're asking you to seek them out as a way of educating. And of course, the other major way of preparing is connecting with somebody who has worked cross-culturally. And you might have to ask your pastor or somebody in your church if there is anybody in the community you're in that has had this kind of experience in a longer term way that can help mentor you, and ask for them to be your discipler. Enter into a discipling relationship with someone who has that cross-cultural perspective. If there's any one thing that our church as a nation in the U.S. and Canada and other Western countries lacks, is a discipleship model that's built on how Christ did it. Where is that person you're accountable to that you're meeting with regularly? That you can do, again, anytime. And even if there isn't a cross-cultural person that you can connect to, you can connect with a Christian who knows Jesus deeper than you've experienced thus far to learn from. And yes, you'll learn some things that you can feed back as well. But if you're not in a discipleship relationship, it's hard for you to be a discipler when you move cross-culturally as well.
Yeah. Well, fantastic, guys. I think it's about all we have time for today. But just, we could definitely, there's hours here that we could go on and talk more. So we'll look forward to the next time. But thank you both for giving us your time and being able to share with us. And for all of you here, it's clear the need is great, and there's plenty of opportunity. I'd encourage you to look into both of these organizations if you're tuning in tonight and feel just kind of pulled towards this type of serving. For others of you, again, would just encourage you, as we always do, to get on that GMHC Go app, look for opportunities. There's always opportunities there for you. I love the call here to just put yourself in the setting, in the community that's going to keep you on mission. You're going to be really influenced by the people that you're around. And so glad you could join us tonight. We look forward to having you at our next virtual event.